Ladies and gentlemen, good evening and welcome to the first online seminar of the Cambridge Enterprise and Technology Club. Thank you for bearing with us while we hosted first the BBC. We've just been live on BBC Look East, and then while the friends here from Supernova did a quick transfer into new tech for this online seminar, so thank you for your patience with that. Good evening. This evening we will hear from the inside story from a panel of leading experts on the coronavirus and on the global impact of the coronavirus. My name is George Neville-Jones. I'll be your host for the evening. I'm the Secretary of the CETC and I'm also the Local Director of Metro Bank, the Challenger Bank in Cambridge. I'm pleased to introduce our panel to you as follows. So, to my right here I have Dr. Chris Smith. Chris is a scientist and broadcaster based in Cambridge. Alongside his work as a virologist at Addenbrokes Hospital, he lectures at the University of Cambridge and presents the Naked Scientist podcast. He hosts weekly scientific radio shows on the BBC and on ABC in Australia. Throughout the coronavirus outbreak, he's been called upon very regularly as a subject matter expert by both media and government, appearing on the BBC, including tonight on both PM and then on BBC Look East. Dr. Freya Jephcott is an expert in outbreak surveillance and response systems, particularly those in sub-Saharan Africa. She works at the intersection of medical anthropology and applied epidemiology. In addition to her research at the University of Cambridge, she works as a manager of epidemiological activities for Médecins Sans Frontières, performing disease outbreak investigations. She is also a consultant on the strengthening of global health systems for the World Health Organization. Dr. Flavio Toxver is an economist at the University of Cambridge. He published The Economics of Vaccination in 2014 and maintains a research focus on the optimal control of infectious diseases. In 2019, he facilitated the International Monetary Fund's Antimicrobial Resistance and Pandemics Symposium in Washington, D.C. To my immediate right here, Dr. Peter Buchan. Since his PhD in pharmacology at the University of Edinburgh, Peter's worked within drug development businesses in executive roles. He's a clinical pharmacologist with deep knowledge of disease impact modelling, and he's monitored the Italian and UK responses to COVID-19 carefully. Furthermore, he's involved in the development of relevant drugs to solve this crisis. Please do submit questions during the seminar, using our YouTube channel in particular, and for the moment we'll hand over to pre-submitted questions for the panel. So, I'd like to start with a question for you, Chris, and it's a question that's been bandied around a great deal. Why can't we test infected people for the virus before they show symptoms?
Well, we can, George, but the way we're testing at the moment is we're taking swabs from the nose and the throat, and they collect cells and virus particles if they're there, and then we extract from those swabs the genetic information from the virus. And then we copy it millions of times, and then we add another chemical that's called a probe, which, if it sees the right sequence of genetic information corresponding to this virus, it makes a colour that we can see. Of course, it's only any good if there's enough virus there for you to detect. And when a person first gets infected, the amount of virus that'll be there is very small, and therefore it's possible to generate what we call a false negative, because you take a swab, the test would say negative, but that's because you didn't swab the right bit of your nose or throat where all the virus was at that time. Now, if you'd come along a day or so later, there would be more virus there, and you might detect it. So no test is perfect, and this test in particular may have other peculiarities because this virus is very good at growing in lung tissue and less good at growing in the nose and throat. So if you just swab the nose and throat, there's also a risk of missing it. So for this reason, we're also beginning to develop other forms of tests, which will, and in the Prime Minister's press conference today, he dubbed this lifting the cloak of invisibility around this virus. They'll look for antibodies, which a person makes when they're infected with the virus, and different types of antibody are made when you're acutely infected, i.e. you've got it right now, compared with when you've fought it off and become immune. And so by looking at those ratios of those different classes of antibodies, we also get some idea as to when a person got the infection. And that's going to be really important because at the moment we're saying to people, if you've got symptoms, go home, don't go to work. And the economic impact of not being at work is going to be really, really stringent, really very, very stiff. And there might be no reason for a person to be isolating for as long as they're having to isolate themselves. If we can find out if they've already become immune to this thing, they don't need to stay in isolation at all.
Okay, understood. And so if people are isolating at home, there's presumably going to be quite a significant impact of that on the economy and that sort of thing. I mean, Flavio, what do you think the economic impact of the virus will be as we see this play out?
Well, in the short term, it's almost incalculable. It's way too early to say something very specific about the numbers. I think there's no doubt that this will have very long-lasting consequences. In the immediate future, there's going to be an impact on labor markets, because people will suddenly withdraw from the labor market. There'll be important disruptions to supply chains, because we rely on production from other countries and from other companies and so on. But going down the road, there will be fundamental changes to the way the economy operates. I hope that this will be a wake-up call, and that it will focus minds on making the supply chains more robust and to make better coordination between countries for early picking up of information and information sharing. So I think just to encapsulate my thinking on the economy, in the short run, I think the economy is not what we should be thinking about. In the long run, we can worry about the economic consequences. Right now, we are in a deep hole we have to get out of.
Okay, understood. But you're talking about increased collaboration between different countries. I'd be interested, Peter, I know you've worked in drug development for a long time. Are we beginning to see that collaboration come through in the way the pharmacological profession is responding to this?
Well, I think very much so, and I think industry from all around the world have been. I'm not sure exactly how many clinical studies are ongoing just now already in this illness, an amazing amount, and they've started obviously in China, where the outbreak was greatest initially. I know several centres are testing already in Italy, and you can imagine under the most difficult conditions. They're trying to keep people alive, they're overcrowding, they don't have analytical facilities, and yet they're wanting an answer to a disease and intervention at all different levels. And I believe as well, this is a very fast-moving field, but the regulatory authorities are very stringent normally on any drug going into humans, be it for a new indication, a disease that the drug has been transferred to, or a completely novel drug. They're relaxing these rules, and just so things can go very much quicker at an international level.
I mean, Chris, as a clinician working within virology, how are you seeing that process of new experimental drugs coming into the health services? Is it something that we're seeing already?
Well, what's interesting to me is that in the last few years we've seen this happen not just with this infection, but with another major outbreak, which was one that Freya, to my left, is very familiar with, and that was Ebola. And for 40 years the world struggled against Ebola, but because it affected relatively few people, only about 1,500 cases in 40 years, people thought it was a low-risk thing, and it was confined to one geography, so it didn't bother anybody very much. And then suddenly we saw this enormous inflation of cases, and it started to spread into, largely because people took it with them when they travelled, into other first world countries, which really focused minds. And within almost no time at all, we had not one, not two, but 3 vaccine candidates. And actually some are now actually being deployed into the field, and we're protecting people against Ebola. And that was one of the fastest developments of a vaccine that we've ever seen. So actually we learned a bit from that, and people have realised that actually we can do these things in a hurry. Just because it used to take 20 years to make a vaccine, it doesn't have to anymore. And we're in this very fast-paced, technologically reinforced world now where we can do things faster, but that doesn't mean we should just go hell for leather and ignore safety, because the crucial consideration here is that if we do this, we do it to do no harm and make people safe. If we do it in a rush and do it wrong, we will make people worse than if we hadn't done it at all, and that would be totally the wrong situation.
But you're talking about the spread there and comparing it with Ebola. I mean, Freya, I know you studied Ebola as an outbreak a great deal. How do the two compare, and how do the containment measures in particular compare?
So I think they're in a sort of the larger epidemiological picture in terms of containment, so stepping away from the sort of pharmaceutical interventions. The big difference is Ebola. I mean, the catch with Ebola is that it's often these outbreaks are occurring in really resource-limited settings. But the trick is essentially you identify people that are suspected cases, you isolate them, you test them, you find all of their contacts, and then you monitor them for 21 days, the sort of incubation period of the virus. And then if any of them develop symptoms, you then isolate them. And this kind of removes potentially risky people from susceptible people, and you sort of curtail the outbreak that way. Now, the reason this is possible is because with Ebola, you're not really infectious until you're symptomatic. So we can just grab people who are symptomatic, and that sort of works that way. Looking at COVID-19, so SARS-CoV-2, it looks like people can actually be infectious before they're symptomatic. And in fact, some people may never actually become particularly ill or obviously sick at all, but still may have some potential to spread the virus. How much these sorts of asymptomatic transmission events are really driving the overall outbreak is unclear. But from some very good modelling coming out of the London School of Hygiene and Tropical Medicine, so Rosalind Ego's group, it's clear that when in situations where you do have asymptomatic transmission, the effectiveness of contact tracing really reduces, which is why we have to do these sort of more overarching interventions with COVID-19 that maybe we wouldn't do with Ebola.
So is it that that distinction here, that some cases just don't show symptoms, is it that which really creates this rapid growth in the virus?
So, I mean, that's definitely a factor here. With SARS as well, we were able to use largely just contact tracing to really curtail it. But there's this potential for not only asymptomatic transmission, so not obviously sick people spreading it, but also just the fact that people can be so mildly ill with cases. It really makes surveillance so much more challenging, and with that, it makes containment a lot more challenging too.
Does that make testing more important in this particular case? Because we can't see it on the skin, visually or behaviourally by coughing, sneezing. So does that not increase the need for testing on a wider scale?
So this is why the WHO, with its current approach, which I think the WHO is still angling to try and bring this outbreak to a close entirely, like that is still the ambition, and even if we don't get all the way there, then at least it will have done a lot of good. This is why they're really pushing for testing. So the Director General of the WHO has been in all the recent press conferences, very much test, test, test. Unfortunately, a lot of countries, especially this early in an outbreak, do not have the capacity to do that degree of testing to catch all the asymptomatic or only mildly ill people. So in countries where it is possible to scale up, the scaling up is going on, as we've seen in the UK, but there are large parts of the world where that is just not on the cards. So we've got to think about different strategies in different places, but also keep a sort of global view in mind, because obviously the strategies we take in different interconnected countries is going to change the outcome.
May I give you a practical example? I'm in touch in Belgium. I've got a son who lives in Ghent in Belgium, and the school's closed down abruptly on Friday. And in his class, the school was due to do a school play. In my grandson, his son's class, the school was due to do a school play, which was cancelled. And that was cancelled not because of the general cutdown, but because one of the girls in the class was identified as having been positive, who happens to sit next to my grandson. So that means, according to their intentions, that the whole family, my son and his son, although they're completely asymptomatic, should have been tested, but they've run out of reagent.
So that's going to create a real challenge and change the way we respond to the virus, full stop. I mean, Flavio, what's your view here?
Well, it's well known that people's behavior in this kind of situations depends a little bit on the perceived costs and risks of the individual to engage in social gatherings and so on. Now, to the extent that you're asymptomatic, that might actually change your calculation. If you don't know that you have it and you actually do have it, you behave very differently than if you knew for certain. So the fact that the disease is potentially asymptomatic makes a huge difference for the incentives of individuals or people to self-isolate.
And are the measures that we're seeing, self-isolation measures and so on, are they worth it? I mean, people are staying at home, they're changing their lives very significantly. Are we seeing a positive, like to see a positive impact of that immediately?
Worth it in which sense? I mean, it's clear that the economy is taking a hit, but that depends on your idea of welfare. If you think people's health is of first order importance, then it's very much worth it, of course.
Yeah. And Freya, as an epidemiologist, what do you think of that point?
Well, so I think it's good to maybe refer to the imperial model right now. So I'm saying the imperial model. It's this model that was developed largely by Imperial College London, Neil Ferguson's group, which has informed a lot of the policy in the UK recently. Now, this model was looking at some potential scenarios, how this outbreak could unfold with different interventions. Now, they also looked at what is likely to happen if we do nothing. And with the sort of current information we have being fed into that model, it's substantial. So if we do nothing, it was looking at potentially 1 million deaths in the first instance, an overwhelming of the health system. And when we overwhelm our health system, obviously a lot of other diseases and conditions are not treated either. And then we began to look at some of the other scenarios if we do bring in these interventions. Now, the two main ones they identified, there was the mitigation strategy and the suppression strategy. And the mitigation strategy was just trying to sort of slow the spread but not disrupt normal life to too great a degree. So that's the stay home for 7 days if you're sick sort of approach. So that would have made a difference. It would have in fact halved the number of deaths we'd be likely to see. So if we say it was about 500,000 down to about 250,000. And it would have brought down the strain on the health system by about 2/3, which is also great. But unfortunately, as we begin to feed information we're getting, especially coming in from Italy, it looked like that still would have been enough to overwhelm our health system. Which is why we shifted to suppression, which is this more extreme and probably economically and socially costly sort of blanket and more extreme measures. But when we do that with the idea of sort of stopping transmission of the virus as much as possible, ideally totally, but that might be unrealistic, then we do actually bring these deaths way, way down, potentially to 20,000 or even below that, and we really do reduce that strain on the health system. So there are very much benefits to these sorts of interventions, or at least there look to be, but whether they're worth the cost, as an epidemiologist, obviously I believe that reducing the suffering, morbidity, mortality in the community is a necessity. But yeah.
Yeah. So my reading of the report was that they basically looked at the consequences of different non-pharmacological interventions. Now, if correct me if I'm wrong, but there was no policy proposal for mass screening. Now, mass screening might actually change what is feasible to do, and so could actually give us more options that we otherwise might have had.
Actually, so I did see in a statement from the modelers that they were saying that part of this suppression strategy, so they're bringing it down, it could potentially be that it would buy time to scale up testing and consider some other containment ones. So I think that is actually very much on the cards with this, but no, the effect wasn't modelled. Yeah.
I mean, one of the problems is also that there's one issue of doing optimal policy to try to stem this thing, but there's also buying time to learn more about the disease, about how virulent it is, what are the symptoms, and how do we combat it. So we are kind of learning as we go along. So it's a very complicated problem.
Yeah.
Understood. So Peter.
Yeah, I mean, I've got a modelling and simulation background, and so the first thing that I was looking for in those charts wasn't any complex model. I like bringing down things to simple elements, and I would have preferred to have seen a model with what other countries have done. Italy, what's happened there, because they're a little bit ahead of us, and where we are relative to that. And that would, I think, in a very simple back-of-the-envelope type of calculation, gives you an idea of where you are. And I think that sensitises people, and it also lets you decide, should we follow the severe conditions there, or can we get away with less? So if I can bring that down to simple terms, there's different ways of trying to compare the development in different countries, and I know there's a very good site to be a starting point when the country has 100 confirmed cases. But confirmed cases depends when you decide to start testing, who you test on. It's a very, very unreliable variable. So I look at the death rate. And so a few days ago here, we had 21 dead. If you look in Italy, when did they have 21 dead? It was 15 days earlier. We then, both countries increased the next couple of days, and within 4 days, Italy had 71 dead. Within 3 days, we had 71 dead. And now we're going parallel. It was 104, 107, 140 something versus 140 something. That puts us between 14 and 15 days behind Italy. On a practical side, my wife's Italian. She's got family there, I've got a sister living in Cremona, I've been down on lockdown. I look at videos, I listen to people there. When I look around and see how we're behaving here, I'm living in a surreal world, because what's happening there is 2 weeks away from where we are just now.
And how does that? How do the two countries compare their responses?
So
Yeah.
So whilst I absolutely see the merit of sort of taking this approach, we do have to be quite careful about how we extrapolate from other countries. In part, interventions that are feasible in one country, or even the sort of density of population living or the age of the population and such, can be quite different, which means the epidemic might unfold or play out differently in different areas. With Italy, now Italy has the most reported COVID deaths of any country, including China. So clearly we're seeing some of the worst sort of unfolding there. I mean, again, another thing that's going to determine how this unfolds is how susceptible that country is, even with containment measures, to imported cases. How many imported cases are potentially coming in, seeding new undocumented chains of transmission. We've seen in China that almost all of the reported cases now are imported cases. So I think then again we do actually have to be somewhat careful about how much we carry over from Italy, both in terms of the number of deaths we might anticipate, but also the spread. And I guess the other thing is Italy was a bit of a wake-up call for Europe, I think, because...
I'm sorry,
No,
but
please.
again, come back to the back of the envelope for a week now, not on instance of cases, because that fluctuates, but on deaths, we are overlaid absolutely if we just have a lag time of 2 weeks. And I would like to know why we are going to flatten more than Italy, when actually they had more severe measures in place than we have just now.
Well,
Why are we
coming
going flattened when they didn't?
We acknowledge that the measures that are being put in place don't instantly make a difference, and they will make a difference in the time it takes a person who catches the disease today to then turn into a severe case of disease and a death. And that number is about 2 weeks to 3 weeks. In other words, you catch it today, there's an incubation period of, on average, about 5 days. And then from that point at which a person becomes symptomatic, there's a further 12 days before they become severely unwell. So anything we do today, we won't see the death rate change for about 3 weeks. And therefore you've got to anticipate
my
that
point
change.
is, we're not doing things today that Italy were doing 2 weeks ago.
What particular
And
interventions do you want to highlight?
lockdown, you know, that if you go on YouTube and you see the streets there, you know, there's a little village that somebody's beside friends of ours, and there were a few hundred people there. Nobody's been outside the doors for ages, but there's 4 police going around with megaphones telling them all to stay inside.
Yeah, but if I could just clarify, the numbers here at that time were extremely low, and you're taking one small part of Italy and you're saying that that should apply to an entire country, which is quite different. And the economic impact of this, when you think about what the knock-on consequences would be for people with children at school, people getting childcare, people's livelihoods, people's businesses, it's not as simple as saying we just shut everything, because it's not a case of just shutting everything. And it seems that people are calling for everybody to just shut everything without really thinking. And I think the penny finally dropped this week, actually, when people realised that actually what we're doing is buying time, and all these strategies kick a can down the road and they don't provide an answer. And the question still remains, how do we get out of this? And at the moment, no one has provided a convincing exit plan for what we do once we've got everything locked down and, okay, we're testing everyone to death and we've got very few cases, just like China right now. But China knows if it just took all of the suppression off, they would be back to square one. And so would we. And we need this exit plan.
And a big part of that exit plan will be the therapeutics, the drugs that we develop, the vaccines that we develop to combat this virus. And Peter, we talked before we came on air about a number of the measures that have been taken there. Can you talk a bit more about some of those and when we expect those to be available to the public?
Well, I mean, I think there's various levels with the degree of intervention, and on the virology side, Chris will know much more than I do. But my understanding is that there are some of those are working, but they have to be put in early, at an early stage, that when people have got an advanced stage, it's going to be less effective. On the other hand, the area that I'm more interested in is monoclonal antibodies. And one of the reasons that a lot of people are going downhill rapidly and dying is that they have what's called a cytokine storm. And that's the immune system goes AWOL, basically. It releases lots of mediators that cause the capillaries to leak, people get red, they swell up, and in fact, you may remember that in Northwick Park Hospital some years ago there was a volunteer study that went awry there because this overstimulated the immune system. And so so blocking that is key, and there's various points at which you can intervene to try and block it. and one of the most successful so far is an antibody, tocilizumab actimera. It's an anti-rheumatic drug, and it's been trialled in China. It's been used as much as possible in Italy, I believe. The one I'm working in that blocks a receptor of an interleukin-6, and the one I'm interested in actually captures that interleukin-6, and that's key to this cytokine storm occurring.
And so that can help to reduce the impact in the most severe cases.
Yes, so these are being trialled in people that are maybe not at a terminal stage, but at a pre-terminal stage, and it's with a degree of success. However, the antivirals are small chemicals drugs usually. These are monoclonal antibodies, and they have to be synthesized in culture.
Which makes them very expensive.
Expensive and longer to do, so there's a supply chain issue coming here, which personally I don't know the background to, but I would imagine around the world people are trying to up production. And the advantage here is these are existing drugs, so they know the dose to use from other conditions that they're used in. The problem are the longer passages when you come into a new drug, but I don't think we're at the stage yet where we can introduce new drugs.
But as we talked about earlier on in relation to Ebola, we were able to deliver 3 vaccines very, very quickly. And Chris, how quickly
so that's
do
the
we
next
expect,
stage, yeah, that's the next stage.
How quickly do we expect vaccines to be delivered in this case?
The current best estimate is between 12 months and 2 years. And where that's coming from is, although, for instance, one company in Seattle have this week put the first 4 adults through a trial where they have injected a therapeutic into those people, they'll know whether or not this kills people, but they won't know if it protects people. And so they'll grow this into a cohort of people, and then they'll test them over the course of a year. Have we done any harm to these people? The next question you've then got to ask is, when we've done this to these people, are they now making a protective response against this particular challenge? And that takes time to ascertain. And then once you've done that, you then say, right, can we actually scale this and deploy it? And you've got all these important regulatory processes to go through, because it is absolutely critical that if we do something, and this is going to cost a lot of money, to get 7.5 billion doses of this together and then deploy it is going to be monumentally expensive.
Something that's never been done before.
And it's not been done on the scale that anyone has tried to do it. So we need this to happen, but we've got to do it safely, because it's going to be a really big spend. And to spend that much money, you've got to be sure that you're not going to harm people and that what you do is going to work. And therefore it's important not to rush this through and get the wrong thing and hit the wrong target, because the consequences could be actually arguably just as bad as if we hadn't acted.
There's an element of risk-benefit comes in here. So that if you're, treating migraine, it's a severe debilitating disease, but it's not as life-threatening as this, so you have to go more cautiously. And in this particular case, then the first subjects to be trialled with this, I presume, would be the most severe subjects, maybe ones that are beyond responding, but you then gradually go, because eventually you're going to have to give it to a healthy population.
Well, actually,
and
the
that's
people
what
who are the trial
safety-
subjects are just healthy adults.
Yeah,
They're going to recruit
volunteers,
a small cluster, maybe a few tens of adults, and then see how they respond. And these are called phase 1 investigations. And in phase 1 investigations, you put the chemical into people and you have no kind of insight into whether it's going to work. You're actually crucially focusing on the safety, and you're asking, when we do this, does it cause harm? And if you're confident that it won't cause harm, the next stage is to ask, well, does it actually work? And we do this for a reason. We've done this for many, many years in this way, because we know this actually leads to the safe production. Not exclusively, but by and large, the safe production of medicine.
Has this been preceded by animal testing?
The strategy is informed by actually, animal tests, and it's the law that you have to put these things through animals first. But this is not new technology. We've actually used the same approach, or I say the role we're trying the same sorts of approaches which have been used for other members of the coronavirus family in the past and other viruses. And the thing that's attractive is that, unlike, say, making flu vaccines work very well 75% of the time, but they're very, very tough to make in scale. And the reason for that is they're made by and large in chickens' eggs. And it's not trivial to turn around and say, I want 65 million chickens' eggs this week to make. You get about 3 doses per chicken egg. So if you want to treat the population of the UK, that's 20 million eggs straight away. that you need to make 3 doses per egg of 65 million doses.
Chris,
of
we're
vaccine.
not trying to promote panic buying.
No. So the attractive thing about the approaches people are taking for these coronavirus vaccines is they're talking about using so-called DNA vaccines or genetic information vaccines. And what you do is you take the message of what you want to expose the immune system to, and you just put the genetic message into the person. Their own cells pick it up, decode it, and make the thing themselves, and then present that to the immune system and educate the immune system. And this means you can make that in enormous quantities, very cheaply, much more quickly. So there's that. It's an attractive technique if it works. So it's important if we choose our target carefully and get this to work. I think the scaling is less of an issue, which is why we need to get it right. Because I don't see the scaling being a problem, but I see getting the wrong vaccine choice.
We're scaling up the right thing.
Yeah, we've got to scale the right thing.
So I'd like to go on to some of the practical points about how we can mitigate the virus and how it spreads. But just before I do that, just a reminder on questions. We can take questions via the Twitter feed. If you go at CETC, at CAMCETC, CAMBCETC. And I hope as well that the chat function is working on our streaming on YouTube. Although I know that was a bit challenging to set up earlier. But at CAMCETC, CAMBCETC, and that's our Twitter feed, so you can ask questions there. But for now, we're only halfway through our pre-submitted questions. We had a great deal put in. So I'll move on to one of those. And Chris, can I ask you about this? This is very much a practical virology question. Can the virus be neutralised at home? Can we neutralise it on our clothes by using washing machines, dishwashers, that sort of thing? How can we go about protecting ourselves from spread in a more practical sense?
Yeah, it's actually quite easy to kill this off. It's what we call an enveloped virus. If you look at the virus particle, it's pretty small. It's about 1/10,000th of a millimetre across, this spiky meatball-like thing. And the outer coat of the virus is an oily membrane. And sticking out of that are the proteins that it needs to infect our cells. Now, the fact that it's this oily bag around the virus makes it very vulnerable, actually. So if you just use alcohol, and it has to be about 70% alcohol to clean a surface, that will completely bust apart that membrane around the particle and make it non-infectious. Hydrogen peroxide will do the same thing, and bleach will do the same thing. So cleaning surfaces with those things, obviously if you can clean the surfaces with those things, that's the best approach. Also, people often wonder, well, how long then will it survive on a surface? If I cough and splutter these particles out and they land on something, how long do I have to worry? And we're getting quite good data on this now. It looks like the time that it bobs around in the air is a matter of minutes to hours. So after a few hours has gone by, there shouldn't be any viable virus left in the air. But some of it can rain down onto a surface, and it leaves a series of these particles on the surface. And if you touch that surface, you can pick them up and get them on your skin. And if you then transfer those particles to where they need to go, which is your eyes, because the eyes via tears drain into your nose, you might pick your nose, I don't know, it's up to you, or into your mouth, and it can be as trivial as just eating your lunchtime sandwich. We'll put the virus in via that route. You can catch it because the infectious dose is really low. You only need to get about 10 or 20 particles, and the average person who's got this is coughing and spluttering out millions of particles all the time. So it's actually quite easy to get an infectious dose many times over from one encounter with one person. So that's why the advice has been wash your hands. But if it does end up on surfaces, it won't last forever on those surfaces. Some surfaces maybe 3 days at most, other surfaces a matter of minutes. Copper, for example, so the coins in your pocket, they don't remain infectious for very long. Copper seems to be toxic to the virus and denatures it. Other people have been asking me about the mail that comes through your letterbox. Very, very low likelihood of picking up an infectious dose from that. So you probably don't need to, unless you're going to eat your mail or lick your stamps that someone else has licked, probably the risk from that very, very low.
That's good to hear. That's positive. I'm not planning on making anyone
And
else's
presumably the
stamps.
same would apply to clothing, because that's a question that I believe we've had as well.
Yeah, well, clothing is a material surface. The maximum time it could possibly persist would be about 3 days. On that.
As long as that one.
Yeah, but that's a maximum, and these experiments are being extrapolated cautiously from what we know about the flu, and the flu's a similarly structured virus with a membrane around the outside which is quite easy to bust apart, and flu persists for a maximum of 3 days on the surface.
Yeah, I mean, it may be getting too technical, but does that depend on the fact that there's a fluid round about it, or rather than a dry virus that the lab might do when they were doing those tests?
When we cough, what we're expelling are droplets, and those droplets are nice damp droplets which keep the virus moist. And if you have a dry environment with nice hot sunny day, it's going to dry the droplets and dry the virus particles out much faster than if it's a damp environment and it's shielded from bright sunlight.
Understood. So does that mean that we might see this virus diminishing as the hot weather comes around, as people's behaviours change in particular as well, and that sort of thing?
I mean, it's certainly true that you will get more infections in the summertime. More infections in the wintertime. Viruses spread much less well in summer, and the reason for this is because, well, it's several-fold. The chief reason is that when it's summertime, we will go out more, and if we're out more, we're not encountering other infected people. We're not congregating inside, and if you're congregating inside, you're breathing out your virus particles all over each other and trading viruses all the time. And another lesser factor, apart from the temperature allegedly being warmer in the UK in summer, which helps, is that there's less UV light. And some parts, the shorter wavelengths of UV light, the UVB, can break apart the genetic information of the virus, and that means it's less able to spread because it's being deactivated more quickly. That said, Singapore, there are plenty of viruses that spread very well in Singapore, and that's a nice warm hot place. So it's not a given that when the weather's warm you're out of the woods.
Okay. Not something to count on.
The benefit of pushing the current outbreak into summer season is that there are lots of seasonal viruses that are much more common in wintertime, and they include things that put people in hospital, like the flu. And if people are in hospital, they're consuming resources, and those are resources that we can't throw at the present coronavirus problem. So if we can wait for the summertime when there are fewer people who need the help of the NHS for those other seasonal infections, we've got more weapons at our disposal to help people.
So there's actually a wider context point.
Yes,
as well as anything else.
Yeah.
And I guess a behaviour point and the steps that we're taking to isolate and that sort of thing will help with that behavioural point as well. But Flavio, we were talking earlier about the behavioural aspects of this. Is there a point you want to make on that?
Clearly, it's easier to incentivize people to stay home in the middle of a blizzard than it is when it's nice and sunny.
Yeah.
Now, just the fact that people go out doesn't mean that they get close to other people. If everybody goes out and wanders the moors, we're fine. If they all go to concerts and get very close up and cozy, that's a different pattern, right?
Yeah, we've not escaped, the irony hasn't escaped that we're all not doing very good social distancing,
I know.
but we don't have a wide enough angle lens.
This was the surreal part as well. You know, I've got my mask in my pocket. I thought, well, nobody else is wearing it. You know, I wondered, you know, I've been looking, we've been touching our faces. You know, we just haven't got the habits yet.
There is a behavioural change.
But this is a respiratory virus, right? And there's only so much that being a couple of metres away from each other is going to do, because let's get real. When I cough and sneeze, the speed of a sneeze is 100 kilometres an hour, and the particles that come flying out of me if I've got a virus are going to be doing 100 kilometres an hour. 2 metres to something doing 100 kilometres an hour is nothing. And a very infectious virus gets into the air, bobs around on air currents, it's carried all over the place. If you look where the smoke off the end of a cigarette goes, imagine some of those particles of smoke are bigger than the particles of virus. And if you look where the smoke goes, that tells you all you need to know about the likely dispersion around the room. And that's why these things are so good at spreading, because they've had millions to thousands of years to get very good at exploiting our weakness, which is we're a social species and we like to snuggle up to each other.
Could I ask a technical question? The Dyson jet hand dryers, they are rumored to spread fecal matter into the air if people don't wash their hands.
But you know, you're supposed to use them to dry your hands. You're not using them as a toilet.
No. You know what I mean. Yeah. When they dry their hands, is that the same thing with the virus? Is this just a
potentially anything that causes air currents is going to disperse things around the room, and
so better to have a towel.
And that's why I was saying at the beginning of this that I was saying to the BBC, I'm a big fan of just getting a tissue, drying your hands with that, and chuck it in the bin. And I know people say, I've got problems with that on environmental grounds. I don't think that the hot air blower is that environmentally friendly either. There's an enormous amount of electricity goes into running those things, and most of the time it just blows the water on the floor and probably all the viruses up in the air.
But we're leading very nicely into a question scripted earlier for Freya really here regarding the spread of this virus in hotter countries, in the emerging economies in the world, which are particularly affected now. I mean, what do you feel is going to happen there?
Oh, I feel we have to. So there is the WHO flagged this actually in a recent press briefing as well. I guess there's 2 points. One, we think they're not particularly affected right now. I mean, South Africa and Burkina Faso are reporting a lot of cases at this point. But a lot of these countries still have really limited testing capacity.
Mm-hmm.
In fact, a handful of countries have no ability to test for the virus within the country at all. And others are limited to just maybe less than 100 to use in total at present. So a lot of this is still kind of oriented towards trying to pick up imported cases rather than detect community transmission. So, I mean, they are picking up imported cases. Most of the cases being reported in sub-Saharan Africa outside of Burkina Faso are coming from France and Germany and the UK. But I think this is largely because we don't actually know what's going on at the community. The other big questions there on what's going to happen is we don't actually know what the infection looks like in people, say, communities that have a lot of tuberculosis, so TB, in malnourished communities, in refugee camps where you have people living very closely together with even less hygiene infrastructure to sort of mitigate the spread. In a lot of these countries there are somewhat a younger population which could offset some of the severity, but I think that's...
But I was just wondering, even in our population, we talk about dying, we talk about not having asymptomatic, we talk about having disease and recovering. I don't think what's emerged yet is people who are going to have long-term damage as a result of having been severely ill. The lung tissue doesn't heal very well in a lot of diseases, and that's an unknown that we have at the moment.
Yeah, and I mean there's some concern, I imagine one of the sort of more clinical people can weigh in here, but that is a bit of a concern from what was seen with SARS. I think a third of the healthcare workers that did survive has still not been able to return to work because of the severity of the sequelae. But I think actually there was a treatment strategy there with certain kinds of steroids that may have aggravated the long-term damage. I think it's speculated, whereas I know that maybe they'd moved away from that approach with this virus with that in mind, so maybe we might not anticipate. Also, I think generally this disease is a lot less severe on average than SARS was. So maybe the sequelae outlook might not be so bad.
Well, that's a positive at a difficult time. Flavio.
So, just want to make a point that I brought up international cooperation earlier. I think this is a good point that we should bring it back up. So, when I mean cooperation, it's not just in terms of knowledge sharing. In a sense, before we have a vaccine, this is a weakest link type game. That means that even if we do all we can here to do non-pharmacological interventions and we actually bring down infection here, if some country to which we're connected through trade routes or through tourists, they don't get to manage their outbreak, then we haven't really gotten very far. Because we can't shut our borders forever, even though some people might like to think that we can. And so it is actually incumbent upon us in our part of the world to help those countries that don't have testing facilities to actually help them solve our problem. So we have to do it for ethical reasons because they're human beings, but we're also helping ourselves by helping those people.
So if we want to maintain our supply chains, our international trade, our openness to the world, we have to help solve this viral challenge around the world before we can move forward.
I mean global problems need global solutions, and this is a really good example of that.
Yeah.
And it's a bit
So
like
if your neighbor's house is burning, you want to help them out.
you need to put it out or it's going to set fire to yours. And that's exactly the situation we're in. And the problem is, as Freya's alluded to, a lot of these countries have very, very poor health infrastructure.
Yep.
So if you look at the map, it looks like the safest place to be in the world right now is in some of these African countries because they've got no cases. Not true. Actually, they've got plenty of cases, they just can't detect them. And if we ignore that and we put all this effort into destroying our economy to stamp this out, and then we give ourselves a big pat on the back, phew, that's got that over with, and then we take off the brakes, it'll come roaring back from these other countries where it's festering.
So I think I'd like to make the point that this is nothing new. We reflect on this after every significant outbreak. I mean, even maybe smaller, more regional ones like Ebola and such, we draw attention to the fact that without very basic infrastructure and without addressing larger endemic diseases as well and getting health systems up, and I mean, there's not much you can do with these sort of novel, more, these rarer pandemic situations or these sudden outbreaks we really do have to attend to bringing up the basic healthcare infrastructure and public health infrastructure across the whole world, because after this outbreak and however it unfolds, however long it takes, there will be more, and we're going to be sort of, hamstringed by exactly the same things that are holding us back now at a global level. So we really have to make sure, no matter how this unfolds, that we do attend to this.
So we can't be too introverted in the way we react to it. We have to really.
No, we really, this time we have to direct our attention towards.
Yeah, and is there action being taken by the WHO and that sort of thing to try and help upskill and improve the health services in those countries at the moment?
Absolutely. I mean, Africa has the Africa CDC, which is an amazing sort of larger collaborative public health
And
agency.
CDC is.
Centre for Disease Control.
Yeah.
So this is a more sort of Pan-African disease control that works with the district disease control officers, the ministries of health in these countries, and they're really fantastic. And that's a big difference over the last 10 years, having this more regional pool of talent there readily available.
Mm-hmm.
And there is the big universal healthcare push going on at the moment that is targeting sort of basic primary healthcare infrastructure. And so, as much as speaking as someone that does work in sort of the outbreak diagnostic startup world, I would also advocate, though, that when we think about protecting ourselves against emerging infectious diseases in this way, we do really think about the sort of simple stuff, the basic public health infrastructure, and supporting local district disease control officers. I feel like I completely abandoned the original question there.
No, not at all. No, we are naturally very focused on our own world and the impact of this virus on us today, but we have to consider what's going to happen tomorrow.
When a country decides they can lift the door open again, and if one country is spreading it out over a longer term, the other one says, we've got over it, we're clean, that country who's spreading it out is not going to be able to communicate in the same, so there's a lot in economically, I imagine, that impact's going to be enormous.
So it's clear that if a country is very inward looking, they might have a stronger incentive to let people out than to let them in.
Mm-hmm.
Because, if all the people who are infected go to the neighboring country.
We're in a new world.
Exactly.
So we've got a couple of questions in as well, and we've had a question in particular on the economic impact of this virus and the measures we're taking to contain it, and another line of questioning specifically about our reaction as a nation and how we're inhibiting it and what more we can do. So I'd like to cover both of those. The third question that came in was on herd immunity, which was a bandied phrase just over a week ago, and we need to understand a bit more about that. So if we cover the economic question first, the economic impact point first, Claudia, do you want to lead off on what we might expect here? Are we in a recession? Is that likely to be a problem globally?
I have no doubt that there will be a recession. And so many people ask the question, will we recover? And the answer to that question is yes and no. At some point we will come to a situation where we are more stable and where the economy will pick up, but we will probably not make up the lost ground. So there will be a dip in economic activity. Welfare overall will decrease, and it's quite possible that going forward we will be on a completely different growth trajectory than the one we were on originally. So I think so. There will be very.
So you think we can see supply chains having to change to accommodate this, business practices changing to accommodate this sort of issue?
I think there are lots of ways in which we conduct everyday life that will change. So from my profession, I'm in academia, so we have conferences where we meet people all the time to discuss research. That has all moved online. I think teaching will move online. And I think we'll find that once we realize how to do things in a new way, we might not want to go back to the ways we used to do things. So I think there's going to be lots of changes.
Chris mentioned clinical studies, and although there's a big push on clinical studies for the COVID-19, I'm hearing that closing down clinical studies worldwide on various other indications where there's competing drugs, so it's not necessary, for obvious reasons when you actually stop thinking about it. We need the clinicians, we need the staff, we need the hospitals, supply chains, the analytical possibilities, all of those are going to have to be diverted. And the other thing that hasn't been discussed in terms of fatality or victims are the people who are being denied care because of the competition with the care for COVID-19.
So this is Chris Whitty's so-called secondary deaths.
Yeah, yeah,
Okay.
They don't
And I haven't seen any
secondary
data yet.
impact.
Yeah.
So there'll be less research on male pattern baldness then.
Well, I did want to come up, having covered, talk briefly about the economic impact here. I think it'd be really good just to talk about our government's reaction and the impact that's going to have on us as a nation and so on. And we've had a specific question in this regard. I don't know, Chris, if you could unpack that, but you just mentioned secondary deaths as an impact. What do you think the positives and negatives of the government approach currently are?
So what are the government's approaches? The government's approaches are now to try to suppress the spread of this virus. And the mechanism that's being put into play is to say to people, if you've got symptoms of this, put yourself and your family into an enforced state of quarantine for 14 days. Why might that work and why 14 days? The reason for that is it's about a 5-day incubation period, and you can assume that the people you live with are nearly certain to get this from you because it is very infectious. And therefore, if you give it to someone as soon as you become infectious, then they're going to have another 5 days of incubation, so we're up to day 10, and then they've got 5 days to recover, by which time you're the one looking after them. That's where we get this magic 14 or 15 day cycle from. And it's easy to remember then. So that is the current approach, because that way people who have the symptoms remove themselves from the possibility, to the greatest extent possible, of transmitting it on. And the aim of doing this is to create some kind of buffer, almost like a sponge, so that you soak up cases this way, so that you don't end up with such a huge surge, because if it's allowed to run amok and continue to spread as predicted, we would get an enormous surge in cases, and that surge in cases would, at best, overwhelm the ability of the NHS to cope about 30-fold over. In other words, we know how many people are likely to get severe symptoms from this, and that's about a fifth of a fifth of the total cases. And of that fifth of a fifth, comes to about 30 times the capacity of the NHS to look after them. So that's the rationale for saying we want to try and slow this down.
That's where this herd immunity question comes in. I don't know.
Yeah.
Freya, we talked about this briefly before the seminar started. I mean, what is herd immunity and why is it relevant?
So I think the reason that herd immunity is being discussed, though I think it's also been made clear in recent days that whilst it was mentioned in relation to government policy, this was more meant to be as a potential side effect of our strategies, not like the ambition of it. So I think that's good to put that first and foremost. So herd immunity is this, it's sort of what we play off when we use vaccines a lot of the time. So when we vaccinate for measles and such, if we can get enough of the population to be immune to a virus, so not susceptible to getting infected or transmitting it, then that almost creates a sort of a buffer amongst other people that might not be able to, say, get vaccinated or get infected and recover well. And so we try and get this this critical sort of threshold of immunity. Now, what that threshold is changes depending on the virus. So you have measles that's very, very good at spreading to a lot of people. So in a completely naive population, each measles case could easily infect, say, 18 new ones. That's not the case with COVID-19. I think with SARS-CoV-2, we're looking at between 2 or 3 cases in a completely naive population. So we might not have to get quite to that point. But the notion is that if enough people get sick with the virus and recover from it and then are immune, and ideally immune for quite a long period of time, that the virus would not be able to circulate. And just because this has also been around the press a lot recently, it brings what we call the basic reproductive rate, the R0, down below 1, which means on average the effective R0 is less than 1. So it means on average each person is infecting less than a person, and then you don't really get an epidemic curve, it just kind of dies out. If I don't know that we even know like what we would have to get to, and I don't think that that's a very normal strategy in public health, is to just let it burn through. But I'm going to turn to Chris here to talk about how herd immunity might relate to what we know about COVID-19 at present.
Yeah, I kind of regret, it wasn't me obviously, but I kind of regret the fact that Patrick Balance brought this up, because what I think it did was acted as a distraction, and then everyone obsessed about it, and I think it took people's eyes off the ball. what they're aiming for is to try to get as many people to be immune to this thing as possible, ultimately, because that's our exit strategy. Because either we're immune because there's a vaccine, or we're immune because people have caught this. Either way, we need a bunch of immune people, because if we don't have a bunch of immune people and this continues to circulate, it will keep coming back.
Yeah.
And there will be no end to this. And it will keep coming back in big surges, and every time people bear down on it, they'll stop it and then it'll come back again. And herd immunity is just a way of saying that although we don't get everyone immune, there's enough people in the population who are, that the distance between people who can be infected is so big in viral terms that the virus can't make the jump. So it just fizzles out and disappears.
And
And that's what
fundamentally,
we're going.
that's the planned outcome of our current strategy.
Yes, the aim is to arrive at that state.
Yeah.
Whether you get there through giving people a vaccine, or some people get infected, or probably a combination of the two. Now, I've been talking to people who are looking at this, and they're not convinced that this suppression strategy is going to do much apart from slow things down. And in fact, what we're going to do is see it penetrate through the population quite slowly, slower than it would have done if we did nothing, and that will lead to immunity in the people who don't have the severe consequence, i.e. they don't die.
Okay, so I'm conscious of time, and I think what I'd like to do is just ask for a couple of closing remarks from each of our panellists, and then I'll wrap up quickly, and we'll close the seminar. So, I don't know, Peter, you were just looking to interject a closing comment from you on the situation here.
I'm going to do quickly. My question is, if we're wanting to slow this down, I still do not understand, and repeating what other scientists have said, why we are not adopting the full measure that many of our neighbouring European countries have adopted, who are either ahead or not even at our level. And when we're not going to do it. On the other one, the herd immunity, I agree entirely with you. I would have called it red herring immunity, to be honest, because the time scale, and if we're talking about 60% of the population, 40 million people have to have it before it's going to any value. We don't know how immune we're going to be. Somebody who's likely or asymptomatic, by the way, with that immunity, we don't know if it's going to mutate. I'm banking on a vaccine. If just holding enough people going forward until a vaccine comes, if I had to bet somewhere. So
your feeling is that one, the measures, containment measures taken are not strict.
I feel nervous sitting here. I feel nervous sitting here watching how we're behaving when I look around, and I think we've got to test. You've got to know the enemy.
Yeah.
You've got to know where it is.
And how does that fit with your thoughts, Freya?
Also, I mean, as Chris keeps mentioning as well, this whole idea of we've got to have a sense of what the exit strategy might be. But in terms of that exit strategy, when we get to alleviate these sort of social distancing measures or we change that, this is going to depend so much on the information and what we learn through various studies and just empirical observation over the coming months. And so I guess my closing sentiment will be that our understanding of the situation and the situation itself is going to change a lot over the coming months. And that means that our strategy is going to change too. And we all need to be quite receptive to changes, though they can be disconcerting. And so a big part of this is identifying reliable sources of information and trying to keep up to date on what's going on, which I know can be actually quite stressful at times, especially with all this information coming in. But it is a dynamic situation, so we all have to kind of stick it together.
And take it very, very seriously.
Yeah.
Chris?
Well, the Prime Minister described this as a generational or a once-in-a-generation consequence or challenge, and that's absolutely true. I've been doing medicine for 2 decades, and I've never seen anything like this. I never dreamed I would, although I've taught on it and lectured on it about what would happen if it did happen. And I still wake up every morning and I can't quite believe we're seeing this happen. I really can't. I think what I would caution people to do is to not expect a quick fix. This is going to take a long time, and so if we anticipate that we're going to be having this problem for a while, it doesn't make it any easier, but it does make it slightly easier to plan for and to cope with, because it's not like people are promising you, jam tomorrow and then it's never delivered. This is going to be with us across this year, and people need to plan for that. They need to adjust their life and plan for the fact that it's going to take a long time to sort this out, and you shouldn't plan your skiing holiday for next season yet, because it's not a given it's going to happen.
Flavio?
So, in a press conference some days ago, the Prime Minister mentioned that the advice that was being taken was not just from epidemiologists, but also from what he called behavioural scientists. So now I read the imperial report, And I must say to my regret that there was not as much behavioral science as I would have liked. Now, before we have pharmacological interventions like treatments, antivirals, and vaccines, we are relying almost exclusively on behavioral interventions. And given that that is so, I just would like to call on the epidemiological community to come together with people who seriously study behavior for a living. And it turns out there are lots of people in the economics profession that do that in other contexts, in a very sophisticated manner. And I think a lot can be gained from people talking to each other across disciplines.
And that collaboration,
At a distance.
that collaboration and that research effort can really try to solve this. Well, thank you all very much for your comments this evening. So I think to wrap up from the Cambridge Enterprise and Technology Club's perspective, we've heard from an incredibly well-informed panel here. We're very, very lucky to have such a strong panel this evening on various aspects of the virus, the way we're reacting to it, the way we're trying to treat it, how quickly that could happen. But the overarching message we're hearing is that we have to follow the containment and isolation measures that have been put in place and be very responsible within ourselves in that regard to try and slow down this virus. And also at the same time, we have to try and support our own economy. So it's no good sitting at home and spending no money at all. If we can order a takeaway, let's go and order a takeaway, because otherwise the takeaway down the road won't ever be able to sell us a curry again. And as a banker, that's something very close to my heart. We're talking to businesses a great deal, and those families are going to struggle a lot more if they're economically impacted in this way. But the viral element, I think we've covered in a lot of detail. I'm sure that there will be interest in revisiting this topic in future months, and it's perhaps the CETC will run a future seminar in this format, perhaps in a more glamorous venue in the near future. But thank you very much for being with us. Thank you for bearing with our slightly delayed start time, and we look forward to hearing feedback and questions and so on our seminar in the future.